last but not least, 3 questions. Should we support the luteal phase with first progesterone, aspirin, or estradiol? Progesterone, Salim, it's for you.
Yeah, progesterone, I think that there is sufficient evidence in both, well, at least in the GnRH agonist cycles, that we should support it because of the suppression of the corpus luteum that occurs and a lower pregnancy rate. In the antagonist cycles, there are no randomized trials, but if you look at the evidence regarding the hormone profile in the luteal phase being suboptimal compared to a donor cycle, it makes sense to support the luteal phase with progesterone. I think that is a fairly standard approach. I don't think anyone is not supporting it. The question becomes, when do you stop the support? And I think that's still not been resolved. And by what route as well, as Peter said, that we don't really know what the optimal route is. But the idea is that you need to support in these agonist and perhaps antagonist cycles.
And the way of progesterone, oral, vaginal, and so on?
That has still not been resolved because there have not been enough trials comparing the different routes. It seems like they all have a role to play. Which one is better and which one is worse depends on patient preference, the side effects, and the use in the clinic. They all seem to work.
Yes, I think it's decided that we have to supplement the corpus luteum phase with progesterone in agonist and also in antagonist cycles. We use a vaginal route, and I think this is the route most of the groups use today.
Well, it's not what we do. And particularly not in older patients or in women with prematurely diminished ovarian reserve. We did probably 12 or so years ago a study where we randomized patients to different progesterone supports. Three groups had progesterone support, but one was suppositories, one was cream, and the third one was a combination of suppositories and intramuscular. And we found really absolutely no difference in younger patients, but we found a very significant difference in pregnancy rate in older patients above age 40. And that kind of logically, at least in my opinion, makes sense because the corpus luteum in older women does not function as well as in younger women. And so I personally think that progesterone support is more important in older women, and we therefore in older women always give IM still, despite the pain, despite the discomfort, we still give IM progesterone. Sure, Dave.
We don't have intramuscular administration available in France, so we use only oral or vaginal supplementation of progesterone.
Question?
No, normally we use in vaginal. I mean, it's better.
And what is the minimum dose of vaginal progesterone for luteal phase support?
The dose.
What is the minimum?
Minimal dose.
There have been no dose-response experiments done. Most people are using lots of progesterone. They use about 600 milligrams, 200 milligrams 3 times a day. But there have been no dose-response experiments done.
Comment? Then we move to the following question about estradiol. Estradiol supplementation?
Again, if you look at the evidence with respect to estradiol, there is conflicting information. Some studies showing that there is benefit and others showing that there is no benefit. The recent review of all the trials would indicate that there is really no significant benefit from adding estrogen. But I think that our assessment of which patients needs it and which patient doesn't need it needs to be improved. And there's now work going on to look at the ratio of estradiol to progesterone in the luteal phase and supplementing those cycles where the ratio is not optimal. The problem is that we don't know what the optimal ratio is. So the first job would be to try and look at what the optimal ratio is and then correct it in those patients in whom there is a low or a high ratio situation. But right now, based on all the evidence that we have to date, there is no overwhelming support for the use of estrogen. There is a tendency towards supporting it, but not statistically significant yet. So the jury's still out on the addition of estradiol until we get more information.
Yes, we don't use it. Excuse me.
Okay. Do you use it?
We use it.
Estradiol supplementation?
Yes.
In every case?
Every case. And I know that there is no
enough evidence.
evidence basis, but it's the only thing that in our department is a magic attitude.
But you use 17 beta? You use 17 beta estradiol?
Yeah.
The natural. Okay. 2 milligrams.
We use immediately as progesterone, on the luteal phase by transdermal administration patch. With aspirin and everything during 8 weeks.
We use it selectively.
Could I ask a question?
We use it selectively.
Wait.
Sorry.
Sorry, this is just to Salim. Do you know of any data where it's detrimental? The reason I ask that is I'm not sure we still understand in the human, but in the animal species it depends upon whether the embryo secretes enough estrogen. Did you not? Sorry. I just wanted to know whether you knew of any evidence where it was detrimental.
Of what?
Oh, detrimental evidence from estrogen.
Well, you have all the egg donation program. You get estradiol for all along until 8 weeks or 9 weeks, and we don't know of any detrimental issues with that.
The only detrimental effects are from the use of birth control pill in patients who inadvertently were pregnant and were taking that, and there are all kinds of teratogenic.
Not effects. Even that. I think that even this was excluded already. This was very old data, and it's excluded. But if you're talking about 17 beta estradiol, where you're using it for every egg donation program almost.
Yeah, and it may not be simply that, but the reason I ask is because in animal data, the implantation depends upon the secretion by the embryo. We don't know the answer in the human, and it may well be just to cover it, it might be beneficial, because there may be, again, specific patients or specific embryos that are too weak at the time of implantation with their estradiol secretion, if indeed it's important for the human, and we don't have the answer.
Well, we have some information from the humans about a drop-off in estrogen level. If there's a rapid drop-off from the time of HCG to mid-luteal phase, then the likelihood of pregnancy is significantly lower. So we know that there is a role for an optimal estrogen level. The question still is, what is that optimal level? Because if it's too high, based on the rodent data, there is a lower chance of pregnancy. So I think we need to find what the optimal environment should be. And until we look at that much more carefully and comprehensively, we'll still be in the dark in terms of determining whether we should or should not replace them. And I think that's where the challenge is right now.
I think that there are many studies that showed in the past that when we stimulate in the IVF for cycles, the endometrium is in most of the cases not in phase. And I think unless we go and study the endometrium, if we give estradiol or progesterone and to see what's the level in the endometrium itself, and it helps. We shall not be able to answer this question. It's all hypothetical.
Just last point, aspirin, Salim?
I think that aspirin has no role, and in fact all the studies now have shown, all the randomized studies, that there is no effect, except for the one original study from Argentina that indicated there was benefit. All subsequent studies have shown no effect at all. And I think that there is a potential for harm by using aspirin, so we need to be very careful about the use of aspirin, even though it seems to be a fairly universal approach and most people are using aspirin. I would caution people that this is not something that would be appropriate in the face of no evidence of support.
I agree with Salim.
Okay. No comments? Then with that, I think we conclude the session. Thank you very much, the audience and the speakers.
We haven't it. Well done. I was